Hello, I'm doing an online review for online residency program for the topic pneumonia. Okay, let's begin. I did a pre-test before this, but my score was so low, so I'm not including that in this recording. Okay. Outcomes and indicators, pneumonia.
This program is designed to provide an overview of pneumonia, discuss signs and symptoms, and review interventions related to the care of the person diagnosed with pneumonia. The program will support clinical professionals in applying the best available evidence in practice as it relates to pneumonia. After completing the course, the student should be able to distinguish community-acquired pneumonia, CAP, hospital-acquired pneumonia, HAP, and ventilator-associated pneumonia, VAP. Identify the signs and symptoms of pneumonia. Demonstrate knowledge of evidence-based care for the patient with pneumonia. Click on each item for more information. Value-based purchasing describes care purchased by an insurance company from an organization based on the quality outcome measures for that organization. For example, an insurance company is more likely to pay for care from an organization with better patient outcomes than from an organization with poorer patient outcomes. Reimbursement may also be guided by the use of the outcome measures. Measures that evaluate the results of overall care, for example, mortality, readmission rates, hospital-acquired infection, but that do not evaluate whether or not specific interventions were performed. Pneumonia is an inflammation of one or both lungs or individual lobes of the lungs, usually due to infectious microorganisms. Pneumonia is the primary cause of death for hospitalized patients. Healthcare-associated pneumonia, to include both hospital-acquired and ventilator-associated pneumonias, is also the most common cause of death of all hospital-acquired infections, HAIs, with mortality rates of up to 33%. Risk factors for any type of pneumonia include smoking, being younger than 5 or older than 65, heart or lung disease, immune dysfunction or suppression, diabetes mellitus, and mechanical ventilation. CAP, community-acquired pneumonia, is obtained outside of a healthcare institution. HAP, hospital-acquired pneumonia, occurs more than 48 hours after admission. Other terms used for this condition include healthcare-acquired and, in the past, nosocomial pneumonia. VAP, ventilator-associated pneumonia, is a subset of HAP, associated with mechanical ventilation. Signs and symptoms of pneumonia include persistent cough, often with purulent sputum, body aches, fever, and pleural chest pain. The patient may exhibit dyspnea. If a pleural effusion exists, the nurse will hear dullness on percussion of the affected lung fields. Rales may also be present on auscultation with lung infiltrates on chest X-ray. White blood cells may be elevated on laboratory tests. The patient may also complain of abdominal pain and diarrhea. A chest X-ray is the standard diagnostic test for all adult pneumonia patients. The patient will likely exhibit lung infiltrates. A complete blood count will show elevated white blood cells, also known as leukocytosis. Cultures of both sputum and blood are helpful in the diagnostic process for pneumonia, as well as providing specific information about the causative organism. Blood cultures may also confirm or rule out sepsis. In some severe cases, an elevated BUN level may confirm the need for intensive care. A 45-year-old clinic patient presents with history of fever, cough, and chest pain over the past 3 days. Which of the following diagnostic tests would be essential for this patient? While reviewing a male patient's admission assessment, the nurse recognizes another significant risk factor, besides a history of smoking, that increases his risk of developing hospital-acquired pneumonia, HAP. This risk factor is most likely one of the most difficult decisions for the provider is determining the level of care needed to treat pneumonia. With the Pneumonia Severity Index, PSI, a patient's risk factors are assigned a point value, which is then assigned to a class of severity. The CURB 65, with CURB representing confusion, uremia, respiratory rate, and blood pressure, determines level of care from specific assessment details. CURB 65 may also recommend admission to ICU for higher acuity patients. Evidence-based outpatient care of community-acquired pneumonia includes the following: a chest X-ray to confirm the presence of pneumonia, a sputum gram stain and blood cultures obtained prior to antibiotic initiation, macrolide antibiotics to treat CAP in patient with minimal comorbidities, early initiation of antibiotic therapy, such as before patient discharge from the emergency department, influenza and pneumococcal vaccines as indicated once the infection has cleared, or as routine preventative care from a primary care physician to reduce the risk of pneumonia. Interventions for outpatients, such as chest X-rays, early initiation of antibiotics, and vaccinations, also apply to inpatients. More interventions also apply to inpatients with pneumonia, as described in the table. These additional interventions include use of the CURB 65 screening to determine whether the patient should be admitted to the ICU, sputum and blood gram stains and cultures prior to antibiotic initiation, urinary antigens tests for severe cases of pneumonia, early initiation of antibiotic therapy, preferably in the ED before admission and transfer to another unit, macrolide antibiotic or combination of antibiotics similar to those recommended for outpatient treatment. Discharge from the hospital as soon as the patient is hemodynamically stable, fever-free for at least 48 hours, and with at least 5 days of antibiotic therapy completed. Click on each item for more information. The influenza vaccination is recommended for all healthcare workers and all family members of a patient diagnosed with community-acquired pneumonia. The pneumococcal vaccination is recommended for patients over 65 years old or those at high risk for developing pneumonia. A chest X-ray is a standard diagnostic test for all adult patients with suspected pneumonia. Hospitalized patients may receive serial chest X-rays to monitor the progression, either improvement or worsening of their pneumonia. Obtain all specimens for culture and gram stain prior to starting antimicrobial therapies. For ventilated patients, the sputum culture will be obtained via endotracheal aspiration or bronchoscopy. In some cases, blood cultures are helpful in diagnosing the causative organism, but they are not drawn on all patients with pneumonia. The PSI and CURB-65, among others, are severity screenings that help practitioners determine whether a patient with pneumonia may be treated as an outpatient or as an inpatient. The CURB-65 goes a step further in recommending ICU admission for patients who meet certain criteria. Do not delay initiation of antimicrobial therapies after cultures have been obtained. Patients being discharged or admitted from the ED should have at least the first dose given before leaving the hospital or transferring to another unit. Outpatient therapy usually begins with a macrolide, such as azithromycin. Inpatient therapy may combine macrolide therapy with either a beta-lactam or a fluoroquinolone antibiotic. In review, prevention of pneumonia starts with addressing modifiable risk factors. HAP is diagnosed after 7 days of hospitalization with new onset of symptoms. A chest X-ray should be done to confirm the presence of lung infiltrates, which are an indication of pneumonia. Obtain specimens for culture prior to antimicrobial initiation.
Okay, that's the end of this module.